different pain. So obviously you got, we have a right upper quadrant, left upper quadrant, lower right, and lower left. And then we also divide it into, even more categories which we don't really discuss very frequently. But we also talk about whether it's in the GI tract, whether it's biliary, or whether it's genitourinary. So, and then areas outside the abdomen, we obviously have the retroperitoneum, abdominal wall, and then you can also have like some referred pain that might be from the chest or in the testes, okay? And we'll get into it, but we do have to know the territory to understand where we're going. And it's important to look at the blood supply too. So as you can see on there, we have our celiac, our common hepatic, our left gastric, and then our celiac trunk. So those are the big ones, and then as we move further into the belly, like when we're talking about like mesenteric ischemia and other conditions like that, it's important to understand what some of those vessels are throughout the abdomen. All right, so does everybody remember the difference between visceral pain and parietal pain? So the abdomen is kind of very tricky. So, we always want to talk about, is it right upper quadrant? It could be like your gallbladder. It may be like a pancreatitis if it's like epigastric. But depending on which structure it is, it's going to affect whether it's visceral pain. So like it says on there, they're basically have different fibers for our pain receptors there. So like when we're talking about visceral pain, it's usually like a dull, slow onset. It's usually from like a distension of one of the organs, like a gallbladder is a very common and good example. As it's obstructed, you start to get inflammation there. And it's typically in the right upper quadrant, but as you can see on here, it's not well localized. And as you start treating more and more patients, you're gonna ask them where their pain is, and they're like gonna point everywhere on their belly. So it's very hard, which is why your physical exam is extremely important, because that's when you can elicit from the patient. A lot of times they're going to be tender everywhere, so it's your job to figure out which spot is a little more tender, and your exam is, you'll get really good at it, hopefully. You guys have been practicing on each other. Are you guys starting to feel any difference? Like you can feel a stool burden in, one of your classmates? Is anybody there? No. Well, you guys should start paying attention when you're palpating to what you're feeling in the belly. You should start to feel, actual organs in there. It's pretty easy to feel stool burdens. I feel it on, lots of patients every day when I'm treating them. And then we have our parietal pain. So this is usually an irritation of the peritoneum, which is usually more precisely located. So that's going to be like you might have your right lower quadrant, or if it's your appendicitis, or you have some sort of fluid that's leaking into the belly, it can inflame the peritoneum, and that's when you start to get like it's epigastric, or it's right upper quadrant, right lower quadrant, depending on what structure it is. So it's important to consider these when you're trying to ascertain where their pain's coming from. And then, like we've always, like we talked about in the first lecture, and like you guys have probably heard all throughout IPAP, history is important. So a lot of times you can get everything you need to know from their history, and then your exam is just kind of reinforcing or affirming what you're suspecting is wrong with them, which is why it's important to listen to your patient. But, typical things that are important in the abdomen, obviously, do they have a fever? What's their appetite like? Is there any trauma? They have malaise, nausea, vomiting, diarrhea, any blood coming from anywhere in the GI tract is important, whether it's from the mouth or rectum. And then we have our biliary, which is most commonly we'll see gallstones, but they may start to have jaundice, which can even be from a gallstone too, that's actually moved a little bit down the tract. And so you'll start to see some jaundice in that patient. Typically you'll see it in the eyes first. So it's important you look at their eyes when you're evaluating even an abdominal pain patient. For all my patients, I do a quick HENT, and then I listen to heart and lungs on every patient, and then I do a focused exam. So I'm going to be up to your preference. I would recommend listening to heart and lungs on every single patient, and then do a more focused exam. Like if they came in because they sprained their ankle, you may not have to do a HENT exam if you don't want to. I know they do have, like coding purposes, you have to meet a certain amount of criteria. In the ER, they changed how they code, so they don't care about a physical exam like they used to. We used to have to get to like 10-point physical exam. Now it's based on our MDM, so a lot of times, if it's more, if I can do a more pointed exam, sometimes I'll avoid some of the things, but my recommendation is do it the same way every time, do it the same on every patient. And then you have you're gonna have GU complaints as well, and a lot of that pain will refer into the abdomen. So you gotta be careful with it, and even testicular pain. Like, the way I was trained, if, like in kids especially, if, like pediatrics, if they present with any abdominal pain and nausea, vomiting, I need to make sure I check their testes as well, because a lot of times they may not complain of testicle pain, it could be a torsion and we're missing it. So it's important we consider all these things when we're treating these patients. And then obviously we gotta think about chest pain as well, especially in women, they'll tend to present differently when they have like an MI, so they may present more with like epigastric pain, or they may explain it as abdominal. So a lot of times if they're, typically for me, if they're over 40, I'll get an EKG on as well, and sometimes a trope. But it's gonna be patient specific. And obviously the rest of the history, meds are always important, especially allergies and past medical history. One of the most important questions for the abdomen is, have you had surgery before? So this kind of puts us into different buckets when we're treating them. So if they've had some sort of surgery, then we have to think, okay, well, they have a high, they have a risk for some sort of bowel obstruction, because adhesions is the most common cause of a bowel obstruction. So if they've had a procedure before, we always need to think about, okay, well, can I reassure myself that it's not a bowel obstruction? And that'll help kind of guide your diagnosis or your treatment plan for that patient when you're seeing them. And then, like I said, obviously you want to do a physical exam, same way every time. And what's important is always to look at the vital signs first. And then if it's trauma, obviously a GCS. And then you're going to look at, are they in any distress? A lot of times, depending on where their pain is, they might be splinting in the bed, they might be leaning to one side. So these are all key indicators to their pain and how bad it might be. And then you always want to ask the patient, hey, point to where your pain is. And that's when it is tricky in the abdomen, because they'll point everywhere a lot of times, especially in kids. They're not the best historians, or they're not able to localize their pain as well as some adults will. And then obviously you want to listen to, like I said, you want to check the lungs. Is it a pneumonia? Because sometimes like a lower lobe pneumonia, they may complain of some abdominal pain, or like a right upper lower quadrant, depending on where the pneumonia is. And then obviously our pelvic pains, our STIs, esophagitis. Is this a lumbar pain? Is it flank pain? Is it a pyelonephritis? So these are all important things. We need to look at their back. We need to make sure we're checking CVA tenderness. And then do we need to do a rectal exam? Are they having any complaints? All right. So what do we, obviously we, inspect, auscultate, palpate. We follow the same process, but here are just the different ways to explain an abdomen, especially when you guys are staffing a patient or in your notes, like is it flat, is it rounded, scaphoid, protuberant. And sometimes these can be associated with certain pathology, but typically not so much. Obviously we treat a lot of overweight patients nowadays, so you're gonna see a lot of like at least rounded abdomens, maybe protuberant, you may be in a place where you're treating a lot of like liver failure patients, depending on if you're in a community hospital in a big town. And then, an everted umbilicus, you'll see that frequently, but some people just naturally have them, so it's important to ask if that's normal. And if it's not, then you need to think there may be some sort of intra-abdominal pressure that's causing that. And then our auscultation. So, yeah, auscultation is difficult. The most common things you're going to hear is like, you're going to hear basically like a hyper-resonant vowel sound. So you'll kind of hear hyperactive, sorry. So you'll hear basically just continuous vowel sounds the whole time. And typically, because we see a lot of like nausea, vomiting, and diarrhea, that's what you'll see it in. And then you also have to listen for, hypoactive vowel sound. Then if you're looking like at sometimes with like bowel obstructions, you may hear like a high-pitched squeaky noise is the only thing you hear. So it's like air trying to get through the intestines, and it's like as it's kind of going through. So it is, it is one of the less rewarding exams you can do, but it is important to document it and make sure that you hear some sort of vowel sounds or you don't, and then it'll kind of help guide you along on what you may or may not suspect it is for your differential. And then percussion. So, this is important, and it's also a good indicator when you're tapping on there, like if they have a significant amount of pain with it as well. So that kind of helps you, once you do your light and deep palpation. But if they're already extremely tender and guarding when you're just percussing, or another great technique is when you're auscultating. I use this a lot. If I think a patient is just guarding, and they're kind of overreacting to the pain. A lot of times when you lightly touch your stethoscope on there, they'll kind of jump and guard, and so then you can think, okay, maybe they're not really guarding, maybe, maybe they're having some pain and they're just overly cautious when anybody goes near it. And then, so some of the things you might hear is like, you might hear tympany, which obviously is a sign of, some sort of air in there. And then, is there any tenderness? Like I was saying, if they're peritonitic, you tap anywhere, they're gonna, probably jump off the bed. And then we have, our like heel taps and rebound tenderness, and we'll get into like Murphy's sign and everything else in the further slides. And then another one is obviously just watching them move. So if, it's always great to see if watch your patient walk into a room. That kind of helps you look at them and how much pain they're in. They might, especially like when anybody who has any sort of like urolithiasis or any sort of stone, you can usually see those from a mile away just by the way they're walking and by the way they're sitting in the bed. And then palpation. This is the most important part of your exam. Like I was saying, you guys should get used to being able to palpate everything on the body. I mean, I can palpate basically any muscle and tell you if there's like, sometimes I'll feel stranding in the muscles, I'll feel trigger points. Luckily we usually have two sides and we can compare it. So your palpation is extremely important in not just abdominal pain, but every patient you're treating. And once you get good at it, you'll start to notice, like you'll start, it especially is helpful on the spine, on the back or the spine, because you're trying to decide, do I think this is somebody that, I need to image their spine, or is this some sort of like paraspinal muscle? So it's important that we're good at palpation. I know my last brigade surgeon, he was like rowing. He wasn't in great shape, so I asked him first off, like, why were you even rowing, man? You don't normally exercise. But he basically had upper trap spasm, and I palpated each one. I was like, oh yeah, right here. And I'm credentialed to dry needles, so I dry needle, didn't fix it. He's like, and he's an internal medicine doctor. And he's like, I don't even know I don't understand this. Like, how do you even feel anything different? Because all he does, they can just give a lot of drugs. They have inpatient patients, they round on him. He doesn't actually palpate like any muscles, and really they call on specialty services a lot of time to do any palpation. But it's important because you can find, you can differentiate. Like, is this more muscular? Is it muscular? Do I think it's bone? In the abdomen, obviously, you should be able to palpate some of the organs on exam. Like I was saying, you should be able to feel a stool burden, especially in your classmates when you guys are doing your exam. So obviously you want to figure out where that pain is located. And a lot of times I don't ask the patient. I see you guys do that a lot. Does it hurt when I press here? Does it hurt when I press here? When you're doing your exam, I don't ask them that, or, and this is my style. You can do whatever you want when you're practicing. I just look at their eyes and their face when I'm palpating everywhere, and you can watch for small changes. A lot of times they'll grimace. Sometimes they'll jump off the bed, but typically I look at their face and I kind of watch for them, just like, they'll have a little reaction depending on where you're palpating. Which is why it's important. Now, if you ask if they have pain anywhere, they're going to say they have pain in almost every quadrant, almost every time. If you're asking them that, does it hurt here? Well, yeah, maybe. I think. So it's important to watch their reactions to what you're doing. And then we obviously have our signs on there. Like, everybody, you remember what Rothstein sign is? So you palpate the left side with the abdomen, and then they have the referred pain on the right side for like an appendicitis. Good. And then obviously Murphy's sign when they're taking like a deep inhalation. And usually you can ask them to take a deep breath and do it. Typically I'm watching them and I'm kind of surprising them sometimes. And that's when I palpate to do the Murphy sign to check, and then it's usually pretty obvious when it's positive. And obviously you have your psoas and obturator sign as well, which can be signs for different things. Typically we think of it with like an appendicitis, but it can also be positive from like certain bowel obstructions depending on where the loop is, if it's trapped in the obturator canal. So these are all important findings you should be thinking about. And then I think we have another slide for special tests. The heel tap isn't as great, but since appendicitis is very common in the pediatric population, it's good to have them hop on one leg is a great test too. And it gives you a good indication because kids don't want to be there and they're usually very active. So if they're not, or if they're having trouble hopping on one leg, that might be an indicator. Oh, hey, I think it might be something going on in the belly, maybe an appendicitis. And then obviously pain out of proportion in your elderly patients, especially with coronary artery disease, could be some sort of mesenteric ischemia. I'm sure you've had what I know ortho talks about a lot of pain out of proportion. You've had other classes, but when you see pain out of proportion, it's like, gives you cue your spidey senses, and it's something you may not key in on immediately, but it is a very important finding, and when you see it and start to see, and start to notice it, it's very easy to see, and you're like, why is this patient in so much pain when they have such a benign exam? So it is an important finding, and it's good to pay attention to it when you have it, and it should kind of tingle your spidey senses because you're evaluating them and you're like, well, it's kind of a benign abdomen, there's not a lot going on. But looking at the patient, you're like, this patient looks really sick and in a lot of pain, so something else is going on, and you shouldn't ignore that. And then it's important to do a chest exam as well because a pneumonia can sometimes disguise itself as an abdominal pain. And you might pleural effusions as well. You do your palpation, tactile firmness. Okay, I haven't done that since PA school, but don't. That doesn't mean you shouldn't do it. And then obviously it's very important to check your CVA tenderness, especially in all your abdominal pains. And especially a lot of the flank pain, definitely flank pain, but I usually check CVA tenderness in all of my abdominal pain patients as well. And then, you may or may not do a genital exam depending on where their pain is. Like I told you with the kids, I always check the testicles, and that was taught to me at a children's hospital I worked at. So it was great advice, especially in the little kiddos, because they're not able to explain their pain as well. And it can be referred pain too. There's even muscles, there's even some of your like inner thigh muscles or your adductors that actually have referred pain to the testicle. So commonly we'll send them, people will send them to get an ultrasound to rule out torsion, but it's actually, especially with like young healthy soldiers who are exercising a lot, you'll commonly see that kind of strain there, but it refers to the testicle, so it kind of tricks you. So these are all important findings. That's why I was saying with palpation, a lot of times I'll tease that out, that it's actually their adductor versus their testicle when I'm doing my exam, and so then we, if we can if we can convince ourselves it's not a torsion, then sometimes I'll needle them and improve their pain. And then obviously we need to check our inguinal, femoral rings. You're checking for a hernia. Got a funny story. When I trained at Fort Belvoir, and I was treating this, he was like a full word colonel. He was like, I don't know, like 50s. And I didn't know what he did for a living, but I was checking him for a hernia. Well, it turns out he's a surgeon. Like he was like working at the Pentagon then, but he's a surgeon. And it looked really funny because I didn't have a stool in the room, so I'm like kneeled down in front of his, genitalia. I'm doing this, he's like, no, that's not how you do that. So he grabs my hand, and I'm like, bent down on my knees in front of him, and he's like taking my hand and shoving it in his testicles. There's the ring. Tell me to cough, and I'm like, oh my God, this looks weird. And I had him cough, but it was just funny. And then he told me he's a surgeon and everything. I was like, oh, okay, this makes sense. But it was a great education on how to do the exam appropriately to check it for a hernia. It just looked kind of funny at the time. And then, obviously, pelvic exam, especially in a female, if they're having any sort of suprapubic pain, you can't convince yourself it's like a cystitis or a UTI. Then you got to think about whether it's like a PID, whether it's a tubal ovarian abscess. These are all things we have to rule out when we're evaluating the patient. And then, is there any discharge? Obviously, like I said, the body has two sides, so you want to compare one side to the other, especially on your testicular exam. And then, if there's any concern for, any sort of, bleeding from the rectum, we obviously need to do a rectal exam. Now, obviously, you see in the pictures, if they're coming in with any of this or they're coming in with pain, then we certainly need to obviously evaluate them. Looking at, you commonly will, we might see an abscess there. Most commonly, obviously, is hemorrhoids that we'll see when we have that rectal bleeding, but once again, we don't want to chalk it up to a hemorrhoid unless it's a clear diagnosis. We want to make sure we evaluate them for any other bleeding. And obviously some of our ancillary tests like labs and CDC looking at their, hemoglobin can help us with that. And then prostate exam. And then like the picture there is like a good picture of like a perirectal abscess, which are, I don't want to say common, but I definitely see them quite frequently. Not so much primary care, but in the ER we'll see them a lot. So they'll come in extreme, in kind of extreme pain when it's when it's a perirectal abscess. And then obviously gross blood, we need to make sure we're checking our glove after we do the exam. We don't use those like, have you guys ever heard of the little hemoccult cards that checks for any sort of occult bleeding? We don't use those as frequently anymore, but they still are out there. So that's important for any like microscopic bleeding that you're not seeing or gross blood on your exam. You can check that. And then some of the studies we do, so for belly pain, typically the labs would order for like, we could just call them our belly pain labs or abdominal labs. And that's typically CBC, CMP. Some people get a BMP and a LFT versus a CMP. It only adds one other thing, so typically we just get a CBC, CMP, and then we get a lipase as well. And then obviously urinalysis. Depending on, like I said, anybody over 40 that has epigastric pain, I get an EKG on them as well, and especially if they're elderly. We get an EKG because sometimes it could be an MI that we're missing and mimic abdominal pain. And then what studies can we do? So obviously the bedside one that's the easiest is an ultrasound, which is awesome. And you guys are going to start training in that soon, and you guys should be comfortable with it. I know you're graded on a few different exams. I know the FAST and an ocular one, but you guys will practice all of them. So it's an easy bedside test that you can take a look and see if they have gallstones. Unfortunately, when you call the surgeon, they're still going to want usually a formal one, even though you don't need it. They want to be able to see something in the computer to show them that, it's a cholecystitis. So sometimes you'll have to get a formal ultrasound as well. But the most common test we order is the CT scan. So usually CT abdomen and pelvis with contrast. And there are times you can do without contrast, and we'll talk about those. And then, so, a chest x-ray is a helpful test. On here it says that, so, it's kind of tricky. It is a great test because you can see free air under the diaphragm, and also you can see if it's a pneumonia or anything else that's kind of mimicking it. Nowadays, with the CT scan being so common, we typically just order the CT scan, and it'll evaluate like the base of the lungs there, and they'll be able to find any of that. But for those of you who are going to like roll 1, or if you end up in a roll 2, in your brigade, the only thing you have is a plain film. So that may be the only thing you have, and that would probably be the only times I'm ordering that, like KUB or a chest x-ray, because I don't have a CT scanner, which is helpful because depending on where you're at, if you're in the field or you're deployed, you may have to send them some far off place to get a CT scan. So it's important you guys understand how to read plain films as well, even though we don't use them as commonly for abdominal pain. They can still be helpful in a certain setting. But you guys see the air on the picture there? Do you guys understand what they're talking about? That free air under the diaphragm, that's obviously not normal. And then our plain abdominal x-ray series. So not as commonly used anymore. I use it most frequently in kids just because we don't want to jump to a CT scan in them. And a lot of times it doesn't do anything well really for the abdomen unless there's some glaring obvious error. But what you can see is like a large stool burden is very common. So especially in the kiddos with abdominal pain, it's a lot of times it's constipation. So sometimes I'll order this first, just evaluating for it. And we'll talk about a lot of the different findings, but we use our same A, B, C, D, E, D, F when we're evaluating these. Another tip I can give you is if you order a test, I would make it a habit to look at it. I know you're going to be busy seeing 20 patients in the clinic, but still pull up your x-rays, not just the results, and take a look at them. I mean, I know providers who didn't have impacts access the whole time they're there. I was like, so you haven't looked at a single plain film you've ordered for 3 years? Like, holy cow. They just read the reports. And the reason it's important, obviously, for your education, but it's also important because the radiologist misses things. They miss things all the time, and sometimes you'll catch them and call them like, hey man, do you think it was this? Like, do you not see that? Am I hallucinating? And it's not hallucinating. A lot of times you may think you see something and they'll explain to you, oh, it's this or that. So it's important, if you find something, call them, and sometimes they'll say, oh, I didn't know that. And that's why it's important when you order these tests, you tell them where the pain actually is located. And some places they'll call and yell at you enough times where you start doing it. Instead of just ordering, whatever, I'm just gonna order this chest x-ray or whatever, it's important to put where that exact pain is located. Just because it may not be related, like a funny story, not funny, it kind of sucked. I shoved a nail through my thumb like a month ago. And I had Robin put an x-ray for me, so I went and got this x-ray. And I had a fracture, but it was nowhere near where I shot the nail or the pain was, and I was like, well, that's kind of weird. How did I fracture my thumb? I didn't even know. So it's important to kind of identify, hey, here's where it happened and what we're looking for. All right, so obviously, like I said, your KUB, some places call it an abdominal series or abdominal film, it just depends on where you're located. Historically, it was called the KUB. And it's just, flat and an upright, plus a chest x-ray of the abdomen. The nice thing in kids is you can get the chest, a lot of kids you can get the chest and the abdomen in just one shot, which is kind of nice. The flat film's not as helpful because a lot of times what we can see on these is air in there, so if they're laying down and the air rises up, it's not as great of a film, so it's important that you get an upright with these. And some patients can't sit upright, so sometimes you may not be able to do it. So something to keep in mind, but obviously you should see air in the stomach, small bowel, the rectal sigmoid colon, and that would be like your normal bowel gas pattern. If you see any free air anywhere else, that's when it should start to concern you, or we'll show some films here like what bowel obstructions look like. It's important we know how to read these. All right. What do you guys see on that film? That top right one. What does that look like to you guys? Yes. So it's splenomegaly, and it's kind of pushing that, it's pushing the stomach. It's so it's so enlarged, it's actually pushing the stomach towards the midline, where you usually don't see the air in there. So that's like a subtle indicator. Well, that one's not that subtle, but it could be subtle if you're not reading a lot of these. So it's important to identify everything on there, but splenomegaly is common, especially in trauma or post-viral, some sort of infection. I've seen a lot of young soldiers all the time. Typically we find it on CT, but, and then obviously we have a CT on the bottom film there. All right, and then one thing the KUV does is you can see calcifications really well. Now, the question is, do they mean anything? There are a lot of calcifications that kind of throw you off. Most common are probably phleboliths that you'll see in there. And you'll just see these like kind of small rounded calcifications, typically somewhere around the pelvic region or the bladder, most commonly where you're going to see these phleboliths, which are normal. You see them in a lot of patients, or sometimes most patients. So that's a very common one you're going to see. And then very rarely, like if you're suspecting some sort of aortic aneurysm and all you're doing is a KUV, you're probably wrong in the first place. But if they have some sort of calcified aorta, you may be able to see that, or like that one there is obviously an aneurysm in the picture. So not very commonly found in that, and an ultrasound is a better test for that if you're suspecting it anyway. And we'll talk, I know in the EMED lectures, we'll talk about that. And then here's some of the other calcifications you might see, like, the one in the bladder there is like the concentric rings, which, likely is a sign of cancer. If you saw something that large, that would be concerning. Typically, you're going to be CTing these patients as well if you're having any concerns. But you may be able to see a stone in the bladder. It has to be quite large to see a stone. Even on CT scan, we can't see like 2 millimeter or less stones. So I have a lot of patients where I'm convinced it's a stone, and I still probably think it is. And I treat them for a stone, but the CT didn't show anything on there. Sometimes they can be, if it's less than 2 millimeters, we know. Sometimes we can't visualize them. Sometimes you can. And then obviously you can get those weird, like schistosomiasis, any of those other crazy ones. Don't ever count it out. You never know when you're going to see it. Like I was at BAMC, I had she was like a 50-some-year-old lady, but she had persistent vertigo with nausea, and I was like, whatever. I CT scanned her, it was normal. I was concerned though, like maybe I couldn't get a PO tolerant. I was like, well, I'm just going to admit her. We'll see what happens. And then the next day, the medicine team saw me and was like, oh my God, remember that patient you admitted? I was like, yeah. And she was like, we did the MRI to like rule out a stroke, and she had neurocysticercosis. There's a bunch of worms in her brain. I was like, holy. I was like, okay. Well, I guess it was good we admitted her. I don't know that they did anything for her. And then obviously like pneumoperitoneum, like we can see in the x-rays there, so any free air under the diaphragm, and obviously it's an upright, so it's going to rise up. And that could be from like a perforated ulcer, or it can be from trauma, or any number of causes depending on the patient's presentation. There's a difference there that's demonstrating. So that's the flat film of the same patient, and versus an upright, and the air rises. That's why it's important we get an upright. And then, obviously, like we talked about, there should be normal bowel gas patterns throughout it, and here's what they look like with those patients. So obviously the colon, you should see the haustra, And then obviously the small intestine has, you know, a certain look to it. And then you can see different things past the duodenum. So it's important to look at that air pattern when you're evaluating all your patients. You know, they're never going to look as great as they do on the slides or as prominent, but there are subtle indicators you can see on the plain films. And then still more the same, looking at, you know, looking for any air in there. And obviously, I hope you guys understand how we get there, and there's typically you swallowing it, and then the air passes all the way through the GI tract. And yep, it's typical. You should see some air in the stomach. You should see some air in the colon. Just because you don't doesn't mean they have a bowel obstruction. But if you got the right patient presentation, it should. You know, if they have prior surgeries, they're, you know, not PO tolerant, they've had nausea and vomiting and belly pain, then obviously you might want to think about a bowel obstruction at that point. And then an ileus versus mechanical obstruction. Does everybody understand the difference? Yeah, so obviously you have some sort of, you know, typically mechanical obstruction, there can be any sort of blockage in there, but typically it's from some sort of adhesions from prior abdominal surgery, versus an ileus, which is very common after surgery, especially from the anesthesia. So sometimes, and narcotics as well, sometimes, you know, we have that neurohormonal response and it's not working appropriately, and it typically responds in 1 to 2 days. And we'll talk about some things we can do when it doesn't in the next slide. So, yeah, like it says, they're most common after abdominal operations. And this is from that neurohormonal response. It's a disruption of it. And then you have, you know, lack of peristalsis in your intestines. And a lot of times patients, you know, will complain they're not having any bowel movements, they're not passing flatulence, and then they may or may not have tenderness on exam. And they typically heal on their own. They may have some distension. And then the medication on the bottom is one we can give that helps accelerate GI recovery, and it's very commonly given in these patients, especially post-op, since we see this, you know, I mean, very commonly. So we'll give this medication. Sometimes we'll do like a barium swallow first, but we won't get into that, those protocols right now, but it is a medication we can give. And then obviously, like I was saying, you know, if we have obstruction, it's usually at a single point. You know, typically from some sort of adhesions from previous surgeries or a hernia as well, especially like a strangulated, incarcerated hernia. You have some sort of bowel wall or bowel going through your abdominal wall, and it's cutting off the circulation to it, and which could lead to necrosis. So that's another cause we might see, but that's why it's important, like I said, in the history, have they had any prior abdominal surgeries? And when you're staffing these patients, your attendings in phase 2, that's going to be one of the biggest questions. If you don't say it, they're going to ask, have they had any surgeries before? So I always ask patients with belly pain, do you have any belly surgeries? I don't usually care about all the other million surgeries they had. And then large bowel obstruction, most common is cancer, and then followed by diverticular disease, and then some. Very rarely volvulus, but you will see volvulus, especially in like a pediatric population. It's a more common one. And then there's a picture of the mechanical obstruction there during the surgery. Kind of gross, right? All right. And then here are just some imaging features you might see, whether it's the entire bowel filled with air, you know, dilated loops, you know, looking at the air fluid levels. You know, most of the time we're getting CT scans in these patients, and we'll look at some CT scans in a second on there. You guys want to take a break? All right, take a 10-minute break. This is just your generalized adynamic ileus, which doesn't have a transition point in there. So, you know, those are helpful differentiators if you're getting plain films. Like I said, if that's all you got, then get it. But typically with a CT scan for these, just get better visualization. So, obviously, you know, based on your history, that can help guide you down this. You know, depending on how long they've had it. It's funny, at the bottom it talks about 6 days. I've never seen a patient with a bowel obstruction for 6 days show up. I'm sure it happens. Typically like 1 to 2 days, they can't tolerate anymore. Usually they're not able to hold, basically their NPO, they can't hold anything down. And that usually brings them in, as well as pain, but commonly it's nausea, vomiting. And then it can turn into severe pain. And then obviously they usually aren't having any bowel movements or passing gas. Like we were saying on the last slide, you got those multiple dilated loops of small and large bowel. There should be a transition point, especially on CT. And then plain films, you may see, air in varying different places throughout the small bowel and large bowel. And then like it says on the bottom, the risk for ischemia, depending on how many days it's been going on, obviously is a lot higher, especially after 6 days. If they waited a week, that's a pretty tough person. So, those are obviously important things to consider, especially in your history, and it can kind of help guide you too. Like if somebody's had belly pain for 2 weeks, you're kind of less concerned for an acute cause versus some sort of chronic cause. But you still, obviously, have to evaluate the whole patient, take into account their vitals and how they look. All right, abdominal male has bloating, abdominal pain, anorexia, nausea, afebrile, non-peritonitic but a distended tympanitic abdomen, no bowel sounds, and a mass in the right groin that cannot be reduced. What do you guys think you'll see on plain films? And we obviously just talked about it. So the multiple dilated loops of small bowel are what you're going to see on your exam for an obstruction. Obviously this one has a hernia as well, and it can't be reduced, so you got to worry about strangulation at that point. You guys understand the difference between like incarcerated versus strangulated? And so an incarcerated hernia, you just can't reduce it, and then when it strangulates, it's then obviously some part of the bowel is obviously obstructed and strangulated, and it can lead to ischemia, which can be concerning. So, all right, you got a 53-year-old female, vomiting, colic, abdominal pain for 2 days, no flatulence or bowel movement. And then medical history, hypertension, she had a cholecystectomy, so that should help make you think, like I said, they had some sort of abdominal surgery, because adhesions are the most common cause of an obstruction from prior surgery. So that's why I said history is very important. A little bit tacky at 101, afebrile, abdomen distended, tympanitic, but not peritonitic. You have multiple distended loops, so small bowel, no gas in the colon, obviously small bowel obstruction. Unfortunately, our questions usually aren't this obvious. I hate to tell you guys that on the exam, but some of them will be pretty obvious. All right, let's talk about CT. This is typically the test of choice when you're evaluating the abdomen, and we typically get an abdomen, CT abdomen and pelvis, and typically with contrast. Sometimes you won't use contrast, for, like if you're suspecting a stone or any sort of nephrolithiasis, urolithiasis. The non-con is actually a better study because the contrast lights up like a stone does. When you send a bunch of contrast through, you may not be able to visualize the stone. So that's something you need to consider before you're ordering these tests. Is what is the highest on my differential? If I think it's a stone, then maybe I need to look at non-con versus whether I think it's some sort of other abdominal pathology. Now, if I hate to get technical here, but large enough stones it can see, which large stones are what concerns us, and they can also see hydronephrosis if you use contrast. So a lot of times I'll get a contrast anyway, it just rules everything else out to help me in the abdomen. But if it's like the classic, like I said, that colicky, pain, usually the patient can't sit still or get comfortable, you can kind of tell they have like some sort of stone there. Actually, you don't even need a scan, but it does help, especially if you're worried about hydronephrosis. And we really only do, most stones pass that are under 10 millimeters, and I don't see very many that are over that, but sometimes we do. But obviously, images are created by X-ray. We have slices through the 3 major planes of the body, and then it helps us evaluate a lot more thoroughly what we're looking at in the belly than like a plain film will. And as you can see, all of our structures there and our organs, it does a really good job. It can be overwhelming at first when you guys are reading CT scans, which is why I recommend just reading lots of them. Just look at them all the time. Like when you guys are in phase 2 in your ER rotation, they'll have a PACS viewer up, just go through all the exams on there and just look like, oh, what's this one look like, what's that one look like? Because, you know, we're guilty of, you know, we catch a lot of flack for, they say all we do is CT people, which is kind of true, but there are a lot of patients we don't CT, but, you know, if I have any question, I send them to the Donut of Truth and we'll see what's going on. All right, so IV versus oral contrast. Oral isn't used as commonly anymore. It is in the surgical setting, it can be useful, but we get pretty good visualization with IV contrast, so we don't use it as frequently. But there are a lot of cases that it's important. A lot of people have, like they have their like gastric bypass surgeries. You see that very commonly now. So there are barium protocol techniques we use a lot for that. And then, you know, there are certain patients, especially sometimes if we're worried about some sort of perforation or we want to visualize the stomach and small intestine a little better, we may give them oral contrast. But typically we use IV. Sometimes you use IV and oral. Both are reasonable. You just have to think that sometimes it can be 2 hours after they take the oral contrast that you're going to run the scan, so it may take a little bit longer depending on what you're looking for. And sometimes you may actually have to, a lot of times when you do the oral contrast, the radiologist is in the room there too, so it is a little more time consuming when you do it in a radiologist there. And sometimes you'll be there as well, just watching as you can see immediately instead of waiting for the results, which is very common. You also need to think about, obviously, comorbidities. You know, I'm not going to get into the IV as nephrotoxic argument today. It might be nephrotoxic, we don't think it is, but, you know, we still consider it nephrotoxic because it may or may not have an effect. If they have some sort of kidney disease already, it may affect it, but the studies don't pan out as well, but we still avoid it if they're like creatinines, or if their kidney function is less than 30. So we will still consider it in those, you know, we may not do IV contrast in those patients. And like I said, for the stones, you don't need IV contrast, so depending on their body habitus, like if they have a little bit of, you know, if they have a little bit of fat, sometimes the attenuation from that, your non-con can be still pretty good on, like you can get pretty good images on those folks, almost, I mean, not as good as IV, but close. Now if they're just, you know, a skinny person, it's, you know, not as great for the non-con. But, and the reason we found this out was, coincidentally, there was a IV contrast shortage in like 2021 and 22. So we didn't actually, we could only use them on traumas for a year there, so it's pretty rough for us in the ER. We were like, what are we gonna do now? Like, we ought to just go home. We all joke, like, I guess we won't work anymore. And all we do is CT, this sucks. But actually we found we can use it for, you know, the non-con for a lot of different things, especially based on their body habitus, it was helpful. Then you gotta think about the, you know, metformin, you know, you gotta worry about lactic acidosis. Not as commonly. You'll be surprised at how many patients are on metformin nowadays. Like I think almost everybody over 40 is on metformin. In all honesty, at least the patients I see, everybody's taking some metformin. And we still scan them and it's fine, but it is always important to consider it. And then you gotta look at your patient. Obviously, if they already have some sort of other cause of an acidosis, you may wanna consider not using contrast on the CT. And, you know, if it's an outpatient CT, we may tell them just hold their dose for 24 hours or 48. Go for it. Now, we talk about two different kinds of contrast. So we have one that's water soluble, one that isn't. And what we worry about is if they have a perforation and one leaks into the peritoneum, it can irritate it and cause more problems. So that will kind of help us differentiate which one we use and which times. And it'll be facility dependent too. They may not have, they may only have a certain one versus the other. So there are some other ones out there as well. And then, yeah, you can do like a barium enema. And you can also do rectal contrast as well. And then here's just some of the different contrast studies we can do. Like I said, barium swallow, you can do upper GI series, or the more common ones we use. Lower GI, not so much. Sometimes we may use it in specific trauma patients. Like a pro tip, if they ever trick you in phase 2 and like ask you to go help them with the barium enema, just say you're busy. It's not pleasant. You stick a giant bag of IV contrast into the rectum, and maybe they have better techniques now when you remove it, but it's, yeah, usually a poopy situation when you remove it. Don't let them haze you and trick you into that. I can tell you from experience, it's not fun. And then you have your cystograms, and then we'll talk about the trauma when we use like our retrograde urethrogram and those sorts of studies as well. But the CT does a great job of showing all these. And then here are some other images with like your barium swallows or with, you know, all your different types of contrast, as you can see in the bladder there on the cystogram, the normal CT with IV contrast, and then like your upper GI series that you have there. And then here's just examples of other films with contrast. That one's a KUB with like with IV contrast to do your urethra, so that's, you know, that can be helpful too if that's all you have, or if you want to evaluate the bladder. And then there's your barium enema study. As you can see, it's kind of localized there in the rectum. Looks like they did oral contrast as well with it, as you see it kind of going all the way through the tract. And then other imaging, bedside, ultrasound, great study. I mean, it's great for your right upper quadrant pains. You can also, in kids, we like to start with it for an appendicitis. However, it's kind of difficult to see the appendix. A lot of times in the ER when I have an appendicitis, because we'll ultrasound everybody, and if I have a CT with appendicitis, a lot of times just for training, we go in and see if we can actually see it on the ultrasound, and most of the time I can't, but so it is helpful, and then it's good training and practice as well to go in there when you know they have some pathology. Like, let me see how well I can ultrasound. It is a skill you have to practice to use, which you guys will use them, you know, it'll be especially useful in the ER. They're starting to use it in clinics sometimes as well. They'll have bedside ultrasounds, which is awesome. We're having a push right now where they're trying to get them to the roll 1s and roll 2s so you can have bedside ultrasounds like at your aid stations. They're not there yet, but they should be there at some point in your career. They haven't made it there in my career, but they're getting there. And then, you know, you also have your nuclear imaging studies and your MRI, which MRI is better for soft tissue. I mean, MRI works great for a lot of things. Most facilities, you can't quickly get an MRI. It takes, because, has anybody had an MRI in here? They book them, anybody? They book them like freaking months out at most places when you're trying to get one. So it just depends on where you're at and how that facility is. I know BAMC does them 24 hours a day, and they'll schedule people like a month from now at like 1 in the morning. It's wild how backed up they are to MRI there. Some facilities that are like really big training hospitals or medical centers that have a lot of money, or they're like doing cutting edge therapies, a lot of times they may have MRIs in their ER. I think that was kind of cool, but it's not military. We certainly don't have that right now. I can only speak for the Army though, maybe Air Force or I mean, does Coast Guard even have medical center facilities? I don't know. All right. And the ultimate goal at the end is, what's our disposition? You know, are we able to send them home? What sort of symptoms are they having? Are they keto tolerant? Those are always important indicators. Did I control their pain? And that's something we don't reinforce enough here in these classes because it's not, you know, not as fun for testing purposes. But in real life, we want to treat their pain first before we do anything. So, you know, whatever your preference is. You know, I know, like in the emergent setting, I use a lot of fentanyl. We use a lot of morphine. You know, usually some sort of opiate for this abdominal pain. If you know, they like if they're like a nephrolithiasis, anti-inflammatories work better than opioids, so that's, you know, those are some different medications you can use. But if you do send somebody home, you need to make sure you give them strict return precautions. So obviously any fever, any change in their pain, any pain that's like intractable, obviously if they're PO tolerant, you know, if they're not PO tolerant, and then you need to let them know, like, that, you know, return precautions, come back in. If you don't have the improvement in like 12 to 24 hours, come back. Versus, you know, whether we admit them and observe them, which is very common. And a lot of times we may not do any surgery or procedure, and we just kind of monitor them in the hospital and serial evaluations throughout the day and see if we get any improvement. Because sometimes a CT scan is not a slam dunk, especially for appendicitis. That's one that they'll say on there, it's like equivocal on the CT, and you're like, crap, man, I really think they have an appendicitis. So a lot of times we'll admit them and do serial exams. And then do they need surgery? It's nice if they just need surgery, honestly. That's usually the easiest option there. Because then you go there, and then typically they're going to be, like we said, MPO. And then they'll do the pre-op routine. And then here are just some orders when you admit the patient. it's important to think about all these things, because if you, like, literally, if whoever's working on the floor, your nursing staff and everything, if you don't put this stuff in there, they won't do it. So it's important you consider this, you know, it's not something we're testing you on, but this is important in real life, that you're actually putting in the correct orders for that patient so they get the care they need. And then obviously surgical timing. Like I said, it's important to differentiate emergent from urgent from elective. I know it's hard to hear in the first lecture, but those, you know, are important differentiators for how quickly they need the surgery. And it's important that you read, if you see those in your test questions, you need to think like, okay, what was emergent again? What was urgent? Which one might be the right answer? So if it's an emergency and you choose urgent, it may not be the correct answer. And obviously in real life, your patient is there, so it makes it, you know, everything we talk about are test questions, but in real life, you got an actual patient, so it's gonna be usually pretty easy to differentiate when you have a patient in front of you. But it gives you some, you know, some of the different surgeries that may or may not be emergent versus urgent. Some of it depends on the OR schedule too, and how many ORs you have. So that's obviously something we have to take into account as well. If you only have, you know, 2 ORs overnight, then you may not be able to emergently do surgery on them. So if it can wait, a lot of times they will, and we'll just admit them until they can get surgery in the morning. And not, you know, I don't like to put blame, but it's usually anesthesia that's the problem. They won't come in at night. All right, and then here's some more indications for an urgent operation. So, you know, any sort of involuntary guarding, rigidity, you know, any localized tenderness, and especially when it's severe, any, like, you know, rectal abscesses are one that goes to surgery quite frequently. They need to be drained. It's not something we can do in an outpatient or ER. And then obviously your radiologic findings, you know, is there any air? You see any free air in there? Any sort of bowel distension, small bowel obstruction, especially mesenteric occlusion. So that's one you gotta, like I said, the mesenteric ischemia, pain out of proportion. We didn't talk about angiographies on the CT scan, but that's something else we have to get on top of there, so it looks at all the vessels. So we have to order MR or CT angio with those ones. And then typically endoscopic findings. So depending on where you're at, you'll usually have gastroenterology there, and they do most of your endoscopic exams. And it's usually, if you don't have that, then sometimes the surgeons can do up to a certain point of them, but they may have to get transferred depending on what sort of studies you need. And then, like, here's our orders and what we do for somebody who's just admitted and we were just observing them. So obviously, like I said, pain control, you want an NG tube in there, maintenance IV fluids, whatever labs you need, and then serial evaluations are a very important one. And this is also important, like, you know, we're not fighting in Afghanistan and Iraq anymore, but this was common when I was there. You know, instead of sending somebody and risking some aircraft and other personnel, it's important because you know, they're usually stuck there on whatever outpost or fob you're at. So serial exams are very important. Even if you're not used to it in your aid station, it is something you know, you should probably think about before you're risking anybody else's life to evacuate everybody. And then, you know, if they're going to surgery, you obviously got to get consent. We have to have anesthesia on board. You got to have your whole OR team. Like I said, the schedule. Some surgeries are more important than others, so they may get bumped off the schedule or further along on the schedule, and you may not get to them that day. It's important to explain that to your patient, like, hey, we may not be able to do this today, but we're going to do this while you're here. Just manage their expectations, because obviously they think they're the most, you know, urgent person in the world, and sometimes you have to explain to them everything. All right. So that was a quick abdominal overview. What questions do you guys have for me? We'll get into the meat and potatoes starting on the next lecture of actual pathology and what we do for it. So I know probably kind of boring, but what questions y'all got? Everybody good from the fluid lecture yesterday? Everybody's got a good understanding? All right. Nothing? Cool.